Welcome to Retina Up. I'm Scott Krzywonos.
And I'm John Kitchens.
John, today we have Jorge Fortun from Bascom Palmer on the show. He's going to tell us a little bit about patient conversations and just some, common challenges or unique elements of his practice. But why are we bringing Jorge on? You have a special relationship with him, right?
Yeah, Scott, if anybody who knows Jorge knows that he's one of the funniest, most genuine and entertaining people that you can have. So we were talking about who do we want to have on as guests. We said, look, we want to have people on that are going to be entertaining and have great takes. And I don't think anybody beats Jorge when it comes to entertaining, smart, funny, clever, all those adjectives.
Yeah, he's easy to talk to. But let's stress the smart part. I think Jorge's got a really good social IQ. I think he's probably very good with patients. I've never been one of his patients. I imagine he's a pretty good educator. I imagine that he's somebody who has pretty good discretion if he's dealing with somebody who's unique or somebody special. What are one or two things you're hoping to hear from Jorge about?
Yeah, I think the other aspect that makes Jorge so unique is where he practices. He practices at Bascom Palmer, which is a very unique environment in and of itself. But more specifically, he practices primarily at the Bascom Palmer Palm Beach office, which has its own set of opportunities, challenges, and it makes what he does so unique. So he's seeing a different type of patient than what we see, or maybe it's a type of patient we see, but we see him maybe 5% of the time. And Jorge's...
Yeah, I'd have to think that the patient demographics in Kentucky, where you are, and in especially like one of your satellite clinics, and then Palm Beach, Florida, are really distinct. But I don't know, maybe there's not that much different about the two of them. I mean, pathology is pathology. It comes for all of us in a certain way. But we'll hear from Jorge in a minute. So stick with us. We're going to head to break. When we get back, Jorge Fortun from Bascom Palmer.
Today's episode is made possible by Genentech, maker of Vabysmo, faricimab, SVOA. To hear peer perspectives and case studies on Vabysmo, you can check out their Purple Chair series featuring Dr. David Eichenbaum unpacking what drying looked like in a real-world DME patient treated with Vabysmo. Catch Dr. Eichenbaum and the entire Purple Chair series at vabysmo-hcp.com or click the link in today's show notes.
All right, everyone, thanks for sticking with us. We're here with Jorge Fortun, who practices out of the Bascom Palmer Eye Institute. Jorge, welcome to Retina Up.
Hey, Scott. Thanks for having me. Appreciate it.
So before we get into our discussion around patient questions, we were chatting before we started recording here. What are you most excited about in retina in the coming, say, 6 months, 12 months, 2 years? What are you keeping an eye on that other people should be keeping an eye on?
Yeah. Well, in the next few weeks, ASRS for sure. And hopefully we'll get a chance to talk about that later. But I think, what we're all potentially excited about is how do we achieve the same outcomes in our patients with reduced number of visits and reduced treatment burden? I mean, I think it's a problem that plagues every retina practice out there. Patients are living longer. Patients are getting older, having more eye disease. And really, with the advent of treatments for things like GA that we didn't have before, we're doing more and more injections. And so I think in general, anything that reduces treatment burden is a big, thing to look forward to. And I think what's closest to the end of that pipeline and sort of at the horizon are TKIs. And I think we've got some exciting potential drug candidates with TKIs. And I think the exciting thing is that if we really want to think about it, even though TKIs inhibit VEGF, we can really think of it as combination therapy because we have dual mechanistic inhibition of VEGF, right? And so we're inhibiting intracellularly and through classic sort of binding of VEGF. And in addition, both of the potential upcoming candidates in that category are sustained release or extended release drugs. And so, I think as it relates to choroidal vascular disease with AMD and retinal vascular disease, diabetic macular edema, certainly diabetic retinopathy, I think poses a real opportunity here where we have good data to suggest the VEGF blockade really helps outcomes in these patients, but we've never had a good, let's say, an intrusive, non-surgical way to really manage these patients long-term. And so I think TKIs really are probably the thing we're all most excited about. I certainly am.
So, Jorge, you have such an interesting practice. You practice at arguably the #1 eye institute in the world, at least per U.S. News and World Report for the last 20 plus years. It's been #1 in a location, Palm Beach, that has so many interesting and famous people. I can think of one or two already off the top of my head. Do you see famous patients every day? What's it like practicing in Palm Beach?
I think I don't know what the average demographic age of the Retina podcast audience is. I would say maybe famous for this demographic. I mean, I'm not seeing Ariana Grande or anybody like that. But obviously, we live in a wealthy part of the world, and certainly there are famous traditional celebrities. And then there's a lot of sort of titans of tech and industry. And you know, I would say that that does raise some interesting challenges. Certainly with real celebrities, particularly, potentially political figures and other things like that, there has to be some sense of discretion. And so, we have accommodations for that in our office to do that. But I think also you have very highly educated, whether, they're wealthy, successful, or otherwise successful. And I think that in many ways, speaks to the interaction you have with them. I will say that I try to treat all patients the same. We do have a development office, as I'm sure your practice does, and so some of these patients get sort of VIP treatment as far as office hours. But I think that regardless of how highly educated, how highly successful or wealthy a patient is, that my explanations to people are always sort of the same. And I say I'm not the sharpest tool in the shed, and so I do pride myself in communicating with patients in a sort of simple manner, oftentimes using, metaphors or analogies to explain complex issues. So try to segue away from you trying to get me to break my HIPAA oath here by naming famous patients, but we'll segue into patient communication, which is one of the things that I think I really sort of pride myself in.
Yeah, tell us about that. Like, are there some go-to metaphors that you use when you're explaining either pathology or treatments to patients? And is there, maybe one or two that the audience could use or that you might suggest that they use because
Yeah.
it's rung true?
Yeah. I mean, I think, Scott, you've worked enough with certainly John and myself on other occasions and with a lot of quote unquote KOLs. And you know that we like to hear ourselves speak often. And part of that is using all the appropriate buzzwords that we all use when we're, sitting around an ad board. And it's very easy to fall in sort of that retina speak and to forget that a patient really has no idea. Right. And John, you and I talk to our non-ophthalmology colleagues and often forget that even physicians don't know what the heck we're talking about, right? And even within the world of cornea, they don't know what we're talking about. So, I think it's important to put things in terms that people understand. And I think analogies and metaphors are great to do that. So I'll give you one that sort of blends one aspect of medicine to the other, right? So we were talking about treatment burden before and how it's difficult for not only physicians, but certainly difficult for patients, right? So take DME, right? Diabetes is a systemic disease. There's no cure for it. And likewise, DME requires lifelong therapy. And patients are often frustrated because they are either not seeing improvement or they've seen improvement and they wonder, why do I have to keep getting these injections? And so a lot of diabetic patients are keenly aware of the other problems that they get with diabetes. So one of them being kidney problems, right? And so I tell them, you know, folks, either yourself, because you're on dialysis, or other patients with diabetes have the need for dialysis to get excess fluid off of their body. Think of this as dialysis for your retina, but much better because rather than having to come in 3 times a week, you're having to come in once a month and hopefully with ongoing treatment, less often than that. And so they understand that concept of dialysis for the eye, right? In other, scenarios, AMD, one that I use a lot with AMD, right? When we're talking about geographic atrophy, right? Is we say, well, listen, we've got a car that's moving towards the edge of the cliff. And with these complement inhibitors, all we can do is press on the brakes. And so it's not maybe worth pressing on the brakes when we're right at the edge of the cliff. It's probably better off if we press on the brakes when we're far away from the cliff, right? And sometimes I tell them if the car's moving real slow, it may not be worth hitting the brakes because it's going to take a long time to get to the edge of the cliff, right? If the car's moving fast, you're going to benefit more. And so they understand that in a way of making that decision on whether to treat or not. We know, for example, that's a problem where we have a ton of chair time, right? Talking to our patients about GA, John, you know that.
Mhm.
And so I find that those analogies helps to conceptualize, how to do things. So, and I'm not going to give away all my all my analogies. And if you'd like more analogies, please don't forget to like, subscribe, resubscribe, and like again.
Thanks, all right. Hey, speaking of GA, what is the status of GA therapies at Bascom Palmer and Bascom Palmer Palm Beach?
I mean, I think in broad terms, obviously we've got the two FDA approved complement inhibitors, and as I just mentioned, that's a lot of chair time with patients having to explain that, and obviously the biggest issue in broad strokes that we have there is that we've got something that slows disease down, and it's from a risk benefit analysis, you'd prefer a benefit that is either more robust or would completely stop GA in its tracks. And then the other aspect of it is when you look at the risk side, you're talking about intravitreal injections, right? And so you would like to then have an agent that is not injectable. And so we know that there is several things in the pipeline, including oral agents, subcutaneous agents, and those clinical trials are ongoing and interesting. Obviously, the holy grail, right, is not only to stop the disease but reverse it. And so, get a lot of questions about stem cells, as I'm sure you do. And I think it's important to explain to patients that stem cells, as they're being used in medicine right now, in no arena are they being used in a sort of restorative fashion. They're being used in a supportive fashion, and that we're still a long way away from that in retina, certainly.
Hey, have you had any patients come in that went to essentially knockoff stem cell therapy clinics? Because I know that's a problem in Florida. Your colleague Tom Albini published on this not long ago, talking about how there's been some
Yeah,
progress in addressing them, but they're still around.
yeah. I mean, Scott, you're aware that my friend Tom Albini and John's friend Tom Albini, who's probably, what'd you say, Tom? Maybe in the top 15 uveitis specialists in Florida.
Exactly. Definitely top
Yeah.
15, maybe top 20.
No, he's gonna hear this and he's gonna know I was joking. No, listen, I think Tom is probably, if not the smartest, one of the smartest people I know, and an amazing uveitis specialist. And he, was it 10 years ago, saw a series of patients that were treated at a quote unquote research clinic down here. And they were being injected with poorly prepared quote unquote stem cells, which were really adipose cells spun down in these patients, which were all seen at Bascom Palmer, ended up with horrible, horrible side effects, right? Including, hemorrhagic retinitis and a lot of them went blind. And you bring up a good point, which is that particularly in certain areas, Florida is certainly one of them where you have a concentration of elderly, oftentimes well-to-do patients that are looking for a solution to a problem where there isn't one, fall prey to people that are looking to benefit financially from this. And so Tom actually went up to DC and testified in a congressional hearing. And so, maybe, John, that's a good follow-up episode to talk to Tom. Dr. Albini goes to Washington.
Yeah, it was a really interesting event, and I'm so glad that Tom could address this. Florida is definitely the Wild West. For your patients, Jorge, what what are some of the things that they can do to best prepare themselves for as a new patient visit with you? And what are the things that you just kind of roll your eyes and go, you know what, I can't believe that they did this?
Well, I mean, John, you're a chief resident here, and you're part of the Bascom family, and you understand that because of the fact that we're the number one eye center in the galaxy, according to U.S. News and a Galaxy report, that patients often come to us for forget tertiary referral, right? We're oftentimes a sixth or seventh opinion. We get international patients that come from all over the place, and so I don't know what the best thing a patient can do to prepare. I think that the hardest thing that I have to deal with, and I'm sure at your practice, in Kentucky, you're one of the premier practices in the Southeast, if not the country. You get a lot of second and third opinions. Is I always say that disappointment in any walk of life really comes from expectations and reality not aligning, and so they come in with high expectations, and I always, even though those are certainly some of the hardest visits, I think that part of me delivering that second or third or fourth opinion to them is to just be as honest and as thorough as I can without being overly negative, right? But at the same time, not inspiring any false hope, right? And so sadly, a lot of my conversations end with a couple of phrases, which is that, there is hope for the future. We know scientific progress is not linear; it's exponential. And even within my career, we've achieved things that weren't able to be achieved in the 50 years prior, right? And so we're making advances every day. That's not to say those therapies may benefit you, but we are, constantly in new clinical trials. And then I always say, where medicine ends, what else can we do? And I think it's important when we talk to patients to say, we may not have a treatment for this, but we need to address more than just the OCT, more than just the best corrected visual acuity. We need to talk to those patients like the human beings that they are, right? And let them know that there is help with low vision. I think an area that we don't talk enough about with patients is the psychological and behavioral and mental health aspect to dealing with visual impairment.
Mhm.
And we partner with several groups here in the community to help patients with that. So
You mentioned you've gestured a few times toward clinical trials, right? And patients being somewhat aware of clinical trials. You also mentioned that your patient base is pretty well educated. I get the sense maybe even bordering on nosy sometimes. Do you have patients that come in and are aware of clinical trials and they have a lot of questions? And then if so, how do you set expectations with those patients to say, hey, there's a chance that even if this does work, it's years away. It's not like it's some new product coming out this fall.
yeah, I mean, I think I mentioned that we see a lot of highly educated patients. We see a lot of very wealthy patients too, and there is this expectation that you know they should be able to be enrolled in any clinical trial. I get a lot of international patients. There's this common misconception that this trial is being done in this country or this trial is being done in this country. And there's a lot of sort of myth busting that needs to go on about that. And sometimes, frankly, you know, like you said, there is the need to explain to patients that you may not qualify for this or that this is a phase 2 trial, right? Where we're really just looking at safety before we launch into an efficacy, right? And to explain to folks that what clinical trial development is and that this drug may not be ready for prime time because we frankly are doing the trial to figure out if it works or not, right? And so I think we all have those problems, but as you alluded to, wealthy, highly educated patients, they have different sets of expectations, and I think that's not just limited to my practice. I think with the advent of AI and easier access to information, on the internet, patients are more educated, which I think is a good thing. I just think it changes the challenges we have as physicians. I mean, oftentimes patients will come in with clinical trials I don't even know, and I have to be very honest to not try to BS them and be like, yeah, no, yeah, that one, no, I don't think you're good for that one. I'll sometimes say, listen, I'm not aware of that trial. Let me look into it.
So, Jorge, we've recently seen the release of AREDS 3 vitamins. Patients come in all the time asking, should I take vitamins? Where do you stand? What do you tell patients about vitamins for their eyes?
Yeah, I mean, I think, they're beneficial. I mean, especially in the absence of anything else. I mean, I think we've seen, as you said, data on AREDS 3. I think we've seen follow-up data from the AREDS trials on the potential effects of GA. So I certainly think that they are beneficial, and I do recommend them to any of my patients with intermediate AMD or worse. So I think, yeah, I think they're beneficial.
Do you explain it to them in like a very high concept, just vitamins are good for you, take your vitamins? Or do you get into the biology of why this particular formulation is different than something that they may just, concoct themselves?
Yeah, that's a great point, Scott. I think it is important to do that. Again, you were trying to talk about the patient demographic that I see in Palm Beach. We've got the 80-year-olds, going on 25, right? And so, it's peptide city down here, man. And when patients are 80, they're like, I'm going to make it to 100 easy, And so that is to say that they're taking every supplement under the sun. And so I think it's important, milk thistle and, raccoon dandruff and, elephant toenail clippings and whatever else you've heard. And you have to say, well, listen, the reason I'm recommending AREDS is because AREDS stands for, age-related eye disease study. This was thoroughly well-studied formula, which has now undergone several updates with real clinical trial data behind it. Whereas most, nutraceuticals, so to speak, don't have that kind of science backing them. And so I think it's important to explain to patients why we're recommending that. And that for the most part, any other sort of nutritional supplementation is probably not worth it if there isn't that type of science behind it.
All right, Jorge, thank you for all that information. We're going to keep you with us. We're going to head to break. And when we get back, we want to hear about Jorge Fortun at ASRS.
This episode of Retina Up is brought to you by Ocular Therapeutix.
Ocular Therapeutics is a biopharmaceutical company working to redefine the retina experience across drug development, treatment, and outcomes, starting with wet age-related macular degeneration. Ocular is advancing an investigational product candidate in hopes of helping patients maintain disease control and preserve vision for the long term. To learn more about Ocular's mission to redefine the retina experience, visit ocutx.com.
All right, we kept him with us. This is Jorge Fortun. He stuck around. We let him sit on the couch because he was such a good guest in our B block. John, you wanted to hear from Jorge about ASRS, which is in a couple days.
Congratulations, Jorge. You're the first guest to actually ever make it to the C block. It's usually just Scott and I, but you did such a great job that we thought we would reward you.
I'd like to pull back the curtain a little bit here. Scott kept trying to boot me out of the room, but my mouse finger's way too fast, man.
The software wouldn't let me.
So Jorge, we're on the several weeks eve of ASRS. I love that our good friend Nina Barakal organizing a lot of the meeting. I love that she's doing an amazing job. She's a great planner. And we're 21 years from that famous 2005 Montreal ASRS, where our other good friend Andrew Moshfeghi first presented on intravitreal Avastin. Anchor and Marina results were released. Just very historic. You're going to be at the meeting. What are you most looking forward to, and what are you going to be presenting there?
So I'll tell you, it's funny that you mentioned Andrew Moshfeghi's, sort of, if you want to call it, historic 2005 presentation of bevacizumab, because as many people may not know, Andrew was a fellow at the time, right? He was a fellow at Bascom Palmer, and I think it's great that a fellow was allowed to present that data. And I think, John, you and I have been longtime supporters and part of VBS, where we encourage and promote young, fellows and young early career physicians. And so thing I'm most excited about and participating in this year was sort of Nina's brainchild of retina surgery around the globe. And it incorporates two things that are near and dear to my heart, which are promotion of young surgeons, right? I was very lucky to have you, Andrew, Tom, people of that ilk to be mentors to me, really, when you guys were also just in your mid careers. And I think we're sort of paying that forward with this concept where we're going to have 4 different teams, if you want to call them, of young retina surgeons from around the world. And so that brings in my second passion, which is, international ophthalmology. John, you and I have been lucky enough to go to conferences around the world, and we know how informative it is to see surgical tips and tricks from our colleagues around the world, where, oftentimes, even though we're a big country, right, in the US, we all kind of do things very similarly, and we certainly learn so much from our international colleagues. So at the beginning of the meeting on Wednesday, I encourage you all to come out to Retina Surgery Around the Globe, where you can see some of the best young surgeons around the world, mentored by the likes of Alessandra Rachaskaya, myself, Nina Barakal, Paul Chan, present, and we'll discuss fantastic surgical videos.
That surgery around the world, that's on Wednesday?
Right, you are. Wednesday to lead off the meeting.
All right. Listeners, I will be there. So if you find me, come say hi. We're going to capture a little bit of content there. We're going to be speaking later to Paul Hahn about the PAT survey that's in a future episode. So it's part of the reason that we're down there. It's the main reason we're down there. Jorge Fortun, thank you for coming on Retina Up. This has been a great conversation.
Scott, John, thank you so much for having me. You guys validate parking?
No, it's cash only.
All right. Well, thanks again for having me. I appreciate it.
Retina Up is an editorially independent podcast supported with advertising. Laura Brown is our production and marketing lead, and Liz Hogan is the head of business development. If you're interested in advertising on Retina Up, have a question for the mailbag, or just have a topic you'd like us to cover, send an email to info@retinup.com. Follow us on LinkedIn and visit retinup.com to sign up for our newsletter so you never miss an episode. Like and subscribe to the show whether you're on YouTube or a podcast streamer. Leave us a review if you're feeling generous. And if you like the show or if you found this episode useful, pass it along to a colleague. That really helps us expand our audience. We'll be back next time with a fresh perspective on what's happening in Retina.